welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today we have Matthew Spinello. He's a PGY2 emergency medicine resident at NewYork-Presbyterian Hospital, and he'll be presenting today on Tenecteplase versus standard of care for minor ischemic stroke with proven occlusion, or the TEMPO-2 trial.
To start with our objectives for this presentation, we'll review the currently available evidence and recommendations for the management of minor ischemic stroke. We'll evaluate the methodology and findings of the TEMPO-2 trial, and we'll finally discuss the applicability of this trial to the current management of minor ischemic stroke. So some background talking about our current practices surrounding minor ischemic stroke. Minor ischemic stroke is typically defined as a stroke presenting with a National Institute of Health stroke scale, or NIHSS, of less than or equal to 5. Minor ischemic strokes can further be classified based on the presence of disability, so further delineating them into minor disabling strokes versus minor non-disabling strokes. Disabling deficits have been defined in stroke literature a number of different ways, but one trial, the PRISMS trial, which we'll actually discuss briefly in this presentation, defined it as follows. A deficit that, if unchanged, would prevent the patient from performing basic activities of daily living, including bathing, ambulating, toileting, hygiene, and eating, or returning back to work. Clinicians make this determination of a clearly disabling deficit in consultation with, of course, the patient, but also available family members at the time. An analysis of 93,517 patients with acute ischemic stroke showed that 31.2% of patients that did not receive fibrinolysis due to having mild or rapidly improving stroke symptoms. It was revealed in this analysis that 28.3% of these patients were unable to be discharged home, and 28.5% could not ambulate independently at discharge. Patients in this analysis that were unable to be discharged home had a variety of different dispositions. 1.1% died, 0.8% went to hospice, 10.7% went to a skilled nursing facility, and 15.7% were discharged to acute rehab. Of those patients that were unable to ambulate, 6% of those could not ambulate at all, and 22.5% did require assistance to ambulate. The results of this analysis reveal to us that it's not safe to assume patients with minor stroke will have good outcomes with respect to discharge disposition as well as disability. So this prompted some investigation into the treatment of minor ischemic stroke. So looking at the current guideline recommendations from the AHA, American Stroke Association 2019 guidelines, they have a couple of different recommendations based on the presence of disability and time to presentation. So going through these one by one, looking at their first recommendation. So for otherwise eligible patients with mild but disabling stroke symptoms, they present within 3 hours, they do recommend administering fibrinolysis to these patients. If we extend that out to the 3 to 4.5 hour window for the same patient population with mild but disabling stroke symptoms, it's a lower class recommendation, but they do still recommend considering fibrinolysis for these patients. Where we start to see some differences now, patients now with mild non-disabling stroke symptoms, so an NIHSS of 0 to 5, fibrinolysis is recommended against for these patients if they present within 3 hours, and also if they present within 4.5 hours. So the current position statement is the guidelines is that if there are non-disabling stroke symptoms, fibrinolysis should not be provided to these patients. So looking at some currently existing stroke literature, start with the effective alteplase versus aspirin on functional outcome for patients with acute ischemic stroke in minor non-disabling neurological deficit trial. And this is the PRISMS trial that I mentioned earlier. This trial wanted to find out if there is benefit to IV alteplase administration in patients with minor ischemic stroke presenting with deficits that are determined to be non-disabling. This was a phase 3 randomized double-blind clinical trial, and they included adult patients with acute ischemic stroke presenting within 3 hours of their last known well. They had to have an NIHSS score of less than or equal to 5, and no deficits determined to be clearly disabling on presentation. Patients were excluded if they had a pre-stroke modified Rankin scale, or MRS, of greater than or equal to 2, or they had contraindications to thrombolysis. And I think Sarah touched on the modified Rankin scale a little bit, but just to reiterate, a modified Rankin scale is a score that qualifies patient's level of disability, with 0 being no deficits and 6 being death. A score of 2 or less on the modified Rankin scale typically denotes functional independence and is a common endpoint we see utilized in stroke trials. Patients were randomized in a 1-to-1 ratio to receive either alteplase with 156 patients in that group, or aspirin 325 milligrams with 157 patients in that group. And moving on to the results, the trial was actually terminated early due to below target patient recruitment and some financial constraints. But they did ultimately find that treatment with alteplase did not increase the likelihood of achieving a favorable functional outcome, which was defined as an MRS of 0 to 1 at 90 days compared to aspirin. A couple of caveats with this. So at the time of study termination, less than 50% of patients had completed follow-up. So we do have a pretty small patient population. And for our primary outcome, 78.2% of patients in the alteplase group had a favorable outcome at 90 days compared to 81.5% of patients in the aspirin group. And for safety, 3.2% of patients in the alteplase group had symptomatic intracranial hemorrhage compared to 0% of patients in the aspirin group. So we did see, as we would expect, more bleeding in the fibrinolysis treated group than the aspirin group. This trial, of course, had some limitations. The trial was limited by the early termination, limiting the sample size, and a significant amount of patients being lost to follow-up. Additionally, the determination of deficits as not clearly disabling is a subjective measure, and despite efforts to standardize this process, it's likely that some bias is associated with it. Moving on to the next and last trial we'll talk about before we dive into TEMPO-2. This was the RELIANCE trial, or dual antiplatelet therapy versus alteplase for patients with minor non-disabling acute ischemic stroke. They wanted to determine if dual antiplatelet therapy, or DAPT, is non-inferior to IV thrombolysis in patients with minor non-disabling acute ischemic stroke. This was a multi-center, open-label, blinded endpoint non-inferiority randomized clinical trial, and they included adult patients with ischemic stroke presenting within 4.5 hours of their last known well, with an NIHSS of less than or equal to 5, and no single item on that score greater than or equal to 1. CT or MRI imaging was performed on admission to identify ischemic stroke, and patients were excluded if they had a pre-stroke MRS of greater than or equal to 2, or they had contraindications to thrombolysis. Patients were randomized in a 1-to-1 ratio to receive either IV alteplase, with 367 patients in that group, compared to guideline-based dual antiplatelet therapy with 393 patients in that group, specifically with aspirin and clopidogrel. For our primary outcome, dual antiplatelet therapy was found to be non-inferior to alteplase at achieving excellent functional outcome, or an MRS of 0 to 1 at 90 days in patients with minor non-disabling ischemic stroke. They found that 93.8% of patients in the dual antiplatelet therapy group compared to 91.4% of patients in the alteplase group achieved this primary outcome. And for safety, symptomatic intracranial hemorrhage and bleeding events occurred more frequently in the alteplase group, but they didn't find a statistically significant difference between the two groups. Briefly, for some limitations on this trial, did lack data on vessel imaging on a large population of patients, making subgroup analysis of patients with large vessel occlusion versus small vessel occlusion less powerful. So definitely some limitations here. So now finally moving on to the TEMPO-2 trial, which we'll be discussing in detail today. This was published in The Lancet in May of 2024, so a very, very recent trial. The authors of this trial stated that patients with minor deficits and with evidence of an intracranial occlusion are a subpopulation at high risk for early neurological deterioration. And they stated that this most often occurs within the first 24 hours following the stroke. Most of our landmark stroke thrombolysis trials have excluded patients with an NIHSS score of less than or equal to 5, making it difficult to use high-quality data to guide our decision-making to provide thrombolysis in these patients. The authors did cite a meta-analysis of patient data from thrombolysis trials, specifically including patients with minor stroke, which found a benefit for IV alteplase in these patients with an odds ratio of 1.48. They also noted that some trials, such as RELIANCE and PRISMS, like we just spoke about, exclusively included patients with minor ischemic stroke. Comparing alteplase to antiplatelet therapy have not shown benefit for fibrinolysis to date. So the rationale for performing this trial, despite the existing body of literature, is that neither of these prior trials focused specifically on patients with proven intracranial occlusion. RELIANCE and PRISMS both utilized alteplase as their fibrinolytic agent, while this trial will utilize tenecteplase. The authors believe that there may be some differences due to the longer half-life of tenecteplase and the increased fibrin specificity of the drug. So now moving on to our study design. So they wanted to determine if tenecteplase is superior to non-thrombolytic standard of care in patients with minor ischemic stroke and intracranial occlusion. So it was a multi-center prospective, parallel group, open label with blinded outcome assessment, randomized controlled trial, and patients were enrolled from 48 different hospitals in Australia, Austria, Brazil, Canada, Finland, Ireland, New Zealand, Singapore, Spain, and the UK. So notably, the United States was not included in this trial. Looking at our inclusion and exclusion criteria, patients included in this trial were adults, so over 18 years of age, had an MRS of less than or equal to 2 at baseline, indicating that the patient was functionally independent at baseline. They had to have a minor stroke with an NIHSS score of less than or equal to 5. They had to present within 12 hours of their last known well, which we'll talk more about later, but an interesting departure from our practice of treating patients within 4.5 hours. They had to have direct imaging evidence of intracranial occlusion or indirect evidence of occlusion with a focal perfusion lesion, relevant to the presenting symptoms, and no region of well-evolved infarction concordant with the acute presenting syndrome. They also utilized the ASPECT score or the Alberta Stroke Program Early CT score, where patients had to have a score of 7 or greater. Perfusion imaging was not mandatory. To briefly touch on what this score essentially means, the ASPECT score is a 10-point scoring system that quantifies early ischemic changes in the middle cerebral artery, or MCA, in patients with acute ischemic stroke. This score is based off of non-contrast enhanced CT scans and divides the MCA territory into 10 regions. A point is subtracted from the total score of 10 for each region where there is evidence of ischemic damage. So if we think about a score of 7 or greater, they are looking mostly at patients with evidence of few regions with ischemic change. Looking at the interventions utilized in this trial, in our Tenecteplase group, we had Tenecteplase 0.25 mg/kg with a max dose of 50 milligrams. So I would like to point out that is a departure from our typical practice of a max dose of 25 milligrams in the United States, and this was administered as a single IV bolus. In the standard of care group, all patients received single antiplatelet therapy at minimum. Ultimately, the antithrombotic regimen was chosen by the local study investigator. Guideline-based care was recommended, but ultimately these decisions were made by the local physician. So looking at the antithrombotic regimens that were actually utilized, the most common by far was dual antiplatelet therapy with aspirin and clopidogrel, followed by aspirin alone and then clopidogrel alone. Some patients did receive anticoagulation with heparin or low molecular weight heparin, a DOAC. Some people received aspirin and ticagrelor. And of note, 4 patients in the intention to treat population actually did cross over to thrombolysis and received alteplase. So looking at our trial outcomes, for our primary outcome in this trial, it was return to baseline neurological function at 90 days following randomization. And they had some caveats for this. So if the premorbid MRS was 0 to 1, then an MRS at 90 days of 0 to 1 would be a responder. For our patients with a premorbid MRS of 2, then an MRS of 0 to 2 at 90 days would be a responder. So patients did not have to go below their premorbid MRS to meet the primary outcome. For some key secondary outcomes, looked at achieving an MRS of 0 to 1 at 90 days, achieving an MRS of 0 to 2 at 90 days, return to premorbid MRS score at 90 days, and all-cause mortality. For safety outcomes in this trial, they looked at the proportion of patients with major bleeding within 48 hours after randomization. For major bleeding, to just kind of give some definitions, major bleeding included symptomatic ICH alone, as well as a composite of symptomatic ICH and major extracranial hemorrhage. Symptomatic ICH was defined as a new ICH, so this could be intracerebral, subarachnoid, intraventricular, or subdural hemorrhage associated with clinical evidence of neurological worsening, with clinical worsening further defined as the NIHSS score worsening by a minimum of 2 or more points different from baseline, and major extracranial hemorrhage was defined as life-threatening bleeding, resulting in hemodynamic compromise or hypovolemic shock, requiring inotropic support or other means to maintain cardiac output, requiring blood transfusions of more than 2 units of packed red blood cells, or associated with the fall of hemoglobin greater than or equal to 5, temporally related to our treatment. For statistical analysis in this trial, sample size estimation was based on a predicted effective size of 9% absolute risk reduction. A favorable outcome rate was estimated to be 60% in the control group and 69% in the Tenecteplase group. Based on this sample size of 614 patients in each group was estimated to be needed, so 1,228 total. The primary outcome was analyzed in the intention to treat population, which included all patients randomized to a treatment group that did not withdraw consent. The primary outcome analysis was unadjusted. So of note, this trial was terminated early. An independent data and safety monitoring committee completed pre-specified interim safety analyses after 100 patients and 450 patients had been enrolled. At the second safety review, there was a signal of excess deaths in the Tenecteplase group. At the planned interim analysis, when 850 patients had been enrolled, the committee ultimately recommended the trial be stopped early due to futility. At the time of the interim analysis, the conditional power to show an effect favoring Tenecteplase was less than 1%. So now getting into our baseline characteristics. So between April 27th, 2015 and January 19th, 2024, 886 patients were enrolled. In our standard of care group, we had 452 patients compared to 432 in the Tenecteplase group. And you can see our baseline characteristics were fairly well matched. Our median age was the same in both groups, so 72, predominantly males, so 60% in the standard of care group compared to 56% in the Tenecteplase group. Looking at our white race, about 85% in both groups, so definitely a significant lack of racial and ethnic diversity in this trial. For some relevant comorbidities, hovering around 20% in both groups had AFib, and slightly less than 20% in both groups had a previous stroke. Important to point out our NIHSS score upon presentation so a median of 2 in both groups. Our median aspect score was actually 10. So if you think back to what the aspect score is actually denoting, this indicates that on average, most patients did not have any evidence of ischemic change on CT. The median onset to treatment time in both groups, if you work out the math here, so was actually outside of our 4.5 hour window for both groups. So 311 minutes was the median time in the standard of care group compared to 293 in the Tenecteplase group. And looking at the type of occlusion, you can see about a little over 10% in both groups had a large vessel occlusion, with the most common being medium vessel occlusions, so a little over 50% in both groups for large vessel occlusions, which they defined as the intracranial internal carotid artery or the M1 segment of the middle cerebral artery. So now getting to our results. So looking at our primary outcomes, so the return to baseline neurological function at 90 days, 75% of patients in the standard of care group achieved this outcome compared to 72% in the Tenecteplase group. This correlated to a risk difference of minus 3.3%, which you can see was not statistically significant. Also looking at our unadjusted risk ratio of 0.96, this also was not statistically significant. Looking at some of our secondary outcomes, so MRS of 0 to 1 at 90 days, you can see numerically more patients achieve this in standard of care group, but there was no statistically significant difference here. For MRS of 0 to 2 at 90 days is where we start to see a little bit of a bigger difference. So 87% in the standard of care group compared to 81% in the Tenecteplase group, which if you look at our risk difference and relative risk, these were statistically significant. Also looking at death at 90 days, so 5 patients in the standard of care group compared to 20 patients in the Tenecteplase group were dead at 90 days with a hazard ratio of 3.9, which also was statistically significant. Now looking at our safety outcomes, for symptomatic intracranial hemorrhage, 2 patients had this in the standard of care group compared to 8 patients in the Tenecteplase group, numerically more in the Tenecteplase group, but as you can see with that p-value, not statistically significant. For any hemorrhage on follow-up imaging, you can see there was a statistically significant difference favoring the Tenecteplase group, so 62 patients there compared to 40. Death within 5 days, again, you can see 8 versus 1 in the Tenecteplase group was a statistically significant p-value, and actually numerically more patients required rescue thrombectomy for the index stroke in the Tenecteplase group. So based on these results, the authors concluded that this trial did not find evidence of benefit in administering Tenecteplase for minor stroke with proven intracranial occlusion compared to non-thrombolytic standard of care. Patients with minor stroke and intracranial occlusion should not be routinely treated with IV thrombolysis. So that's what the authors concluded. To critique this study a little bit before we decide on the clinical application of this study. So the study did have some strengths. It was an international multi-center randomized trial, which is, of course, the level of evidence we would like to see. It had a relatively large sample size, despite actually being the trial being terminated early. Follow-up was completed by nearly every patient that was enrolled, which is a good sign as well. And they included patients only with proven intracranial occlusion, which I personally feel as something different to the existing literature on treatment of minor ischemic stroke. The study, of course, had several limitations, so it was terminated early, which does result in a smaller sample size. They didn't have standardized treatment for patients in the standard of care group, so of course that was chosen by the local study investigator, so that does limit the potential applicability of this trial. The Tenecteplase maximum dose was 50 milligrams rather than 25 milligrams. So while this is a limitation, I would like to point out that only 34 patients did receive a dose higher than 25 milligrams in this trial. So it's unlikely, if at all, that this impacted the results in a significant manner. They also did include patients with the last known well within 12 hours. While there is literature to support administration of fibrinolysis to patients beyond the 4.5-hour window with proven occlusion, this is typically done utilizing perfusion imaging to determine if there is salvageable tissue, which then assists providers in deciding to administer fibrinolysis. They also did not report if deficits were disabling versus non-disabling, which does limit, of course, the applicability of this trial as well. So now for the clinical application of this trial. This trial adds to an existing body of literature showing no benefit of thrombolysis administration compared to antiplatelet therapy in patients with minor stroke. The TEMPO-2 trial showed that the risks of thrombolytic administration to patients with minor stroke likely outweigh the benefits, with patients being more likely to die within 5 days and 90 days, without an increased rate of return to baseline neurological function. Patients were administered fibrinolysis outside of the 4.5-hour window in this trial, and no benefit was seen. Extreme caution should be taken when administering thrombolytics after the 4.5 hours to ensure patients meet the stringent criteria for their use. So either guided by the FLAIR MRI as per the Wake-Up trial or by perfusion imaging as per the TRACE-3 trial. This trial reinforces that there is significant risk to administering fibrinolysis to patients with minor stroke And given that this trial did not specify whether or not patients had disabling deficits at baseline, practice should remain as is outlined in the guidelines, being that thrombolysis should only be offered to patients with minor stroke and deficits that are deemed to be disabling. So with that, I would like to acknowledge my mentor for this presentation, Dr. Judah Brown, for his assistance with putting this presentation together. And I'd like to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.